In my very personal opinion, the missing link is we do a lot of screening for atrial fibrillation, and we think that patients with premature atrial beats, supraventricular extrasystoles have an increased risk of atrial fibrillation, and we should screen them more. But the open question in screening is, if we screen more for atrial fibrillation, we definitely know we will find more atrial fibrillation. The open question is, if we treat atrial fibrillation that is screen detected, do we prevent recurrent ischemic strokes? That is the open question. I lead a large trial in Germany with more than 5,000 stroke patients. That's the FIND-AF2 trial, where we exactly aim to answer that question. So half of these 5,200 patients get heart rhythm monitoring with 7-day Holter ECGs at randomization after 3 months, after 12 months, every 12 months thereafter. Or even if they have atrial premature beats in a certain amount, they get an implantable loop recorder with a continuous ECG monitoring, and the 2,600 patients in the control arm just get usual care. And we look for recurrent ischemic strokes. The trial is powered for 640 primary endpoints events. We currently have 75% of that. Trial results will be available in 2 years from now, probably. And that trial can tell us, okay, is it worth to screen for atrial fibrillation to reduce the burden of recurrent ischemic stroke? And if the answer there is positive, then probably a risk stratification like we have done to do continuous ECG monitoring in patients who have precursors of atrial fibrillation will be answered as well.